With me is Dr. Rajiv Savla. Sir is scientific chairperson for RSSDI 2018. Sir, welcome to the RSSDI TV studio, sir.
Thank you.
So recently, RSSDI has issued diabetes management guidelines. So we will like to know the key messages which the body has conveyed to the large number of physicians who manage diabetes in their day-to-day life. What are the key messages in this guideline, sir?
First of all, I'll let you know the process. 2015, we released the first edition of clinical practice recommendations for type 2 diabetes management in India. And subsequently, the second edition got released this March in IJJDC, which is the International Journal of Diabetes in Developing Countries. First, I must let you know that where is the need for having new guidelines? You have ADA guidelines, you have Canadian guidelines, you have recently passed ADA ESD consensus also, which got published and got presented at ESD itself. See, we Indians are different in terms of diabetes, not only in terms of our phenotype, we are lean thin type. We tend to have diabetes almost 1 to 2 decades earlier as compared to the Caucasian population. Our micro and macro complication risk is much higher as compared to the Caucasian population. Now what we have done is, these are IDF derived guidelines. Derived means we have collected the original document from IDF 2014, and what we have done is we have incorporated all available Indian evidences since 1995, that means almost 30 years published data on various aspects of conceptual aspects of type 2 diabetes, its management and related to micro as well as macro complication. It was very important because having our own guidelines which can address concerns which are much more important for our own population as compared to Caucasian. For an example, I tell you that peripheral neuropathy is much more common in Indian patients or in Asian patients. We tend to have clustering of diabetic nephropathy in families. PVD fortunately is not as common as is in Caucasian population. Similarly, we are much more predisposed for early complication because of one fact, that diagnosis of type 2 diabetes is very much delayed in our population. That is one. And then we tend to have very high HbA1c as compared to the Caucasian. Recently published data told us that HbA1c mean in Indian patient is close to 8.9, which ideally should be less than 7. So that is why we thought that we derive our own guideline based on our own evidence which is available over last 3 decades. So the key points in our guidelines are, what we have done is that we have said, let it be a B, C, D, E, F, G, H approach. That means A stands for age of the patient, B stands for BMI of the patient, C stands for presence of CKD if it is there, or maybe I, micro or macroalbuminuria right from the beginning. D stands for duration of diabetes, E stands for established CVD, because today it is very, very important. Drugs like GLP-1 analog or SGLT2, which will not induce hypoglycemia and tend to reduce overall 3-point MACE or heart failure or CV death, are also getting very, very popular. So we incorporated that evidence also in our guidelines. Then G stands for glycemic status. I told you, if there is a higher HbA1c, we are more likely to have micro as well as macro complication. H is proneness to hypoglycemia. So if you are handling an elderly diabetic who is likely to get hypoglycemia as a result of intensive insulin or as a result of conventional long-acting sulfonylurea, because then it may trigger a stroke or acute coronary event, or maybe at a very high risk for developing sudden cardiac death also. And in the end was F, that is financial status of the patient, which is much more important for an Indian patient as compared to a Western patient, because many patients may not be able to afford the newer drugs. So there we have tried to balance the whole document in such a way that after going through A, B, C, D, F, G, H approach, we tend to have the best combination possible for that patient pertaining to the overall profile of that patient. So we are not biased in favor of a particular drug simply because these are newer drugs, although those are wonderful drugs. We are also not averse from using still sulfonylurea and metformin combination, because those drugs have served our population for 5 decades and we are very, very comfortable even with sulfonylurea. If patient has very high BMI, maybe SGLT2 or GLP-1 will be a very good option. If patient has an established CVD, obviously today good choice will be GLP-1 analog or SGLT2, which will address atherosclerotic cardiovascular disease. If patient has nephropathy, then there are drugs which are safer like teneligliptin or linagliptin, as DPP-4 are wonderful, or you may continue metformin till EGFR is not falling less than 30. So based on the overall profile, we said let it be a individualized approach in the best interest of the patient, seeing the overall profile of the patient, and out of that wheel which we have devised, we say popularly it is a therapeutic wheel by RSSDI. Once you go through that wheel, and in fact we have also now we are coming out with a app also which can take straightway to the best option which will be in the interest of that patient based on the profile of the patient. So it will be very easy for a clinician while sitting in clinic getting that best option possible from various options which are available in that ring or in that therapeutic wheel to have a drug which will be most suited for that particular profile of the patient.
So I think this approach of A, B, C, D, E, F, G, H looks very easier for the normal physician to follow, and he will be able to understand what are the parameters he look into before rationalizing or before deciding onto a drug which he should use. Also, this wheel concept I really liked very much, and I think this is going to help the patients very much. So can you explain a little bit more about the app and how people are going to get access to this app?
Yeah, I must tell you first the concept of wheel. These are different spokes A, B, C, D, E, F, G, H. We have inner circle, which is lifestyle modification, which is there for every patient. Then we have options of drugs. We are starting from green, going towards orange, and in the end we have a red circle. Green means when you have best options, and number of options are available based on the profile of the patient. As you move from the center towards the periphery, from orange towards the red, it is not that drugs which are available in the red circle you cannot use, but those become lesser options. So green circle signifies that there are wider options available. Any drug you can choose based on the profile of the patient. Red circle means your options are getting narrowed based on the profile of the patient. And whenever we are talking of using the therapeutic wheel, what is important is that you try to identify 2-3 main concerns for that particular patient. Say someone who is very obese, who is not a burnt out diabetic, who is new onset diabetic, and by virtue of having a strong family history carries a very strong cardiovascular risk, then for that patient maybe GLP-1 analog will be a best option. Similarly, someone who is towards the other end of the spectrum, patient already has diabetic nephropathy, EGFR is already falling, and patient says towards 60 or 65, there an intense control will not be an option. So there we will not try to induce hypoglycemia on the cost of getting HbA1c 6.5 or 7. So their main concern will be not to induce hypoglycemia, because patient is elderly, already burnt out for 10 years or 12 years, where the risk of CVD or silent cardiovascular event becomes very high. There we like to say relaxed target towards 7.5 or maybe even 8 also, without inducing hypoglycemia. So their drugs like DPP-4, which have a dual route of excretion, will be much safer. And towards the end, if you are handling a patient who has end-stage renal disease, where creatinine is very high, patient is anorectic, is not eating well, always at a risk of getting hypoglycemia, maybe a conventional versus a analog, short-acting insulin analog will be the best option. So that is how, from the therapeutic wheel, after identifying 2-3 major concerns in the profile of the patient, we try to choose the best option which is available and what will be in the best interest of the patient. And that obviously the onus of choosing the drug in best interest of the patient lies on a sensible clinician based on his own prudence as well as based on the evidence, and through this therapeutic wheel it can be helped out. And as I told you, we are releasing that app also, which after fitting all these different information in that profile of that patient will help you. It will sort of simplify your choices. Like otherwise you might have to spend 10 minutes choosing the best drug out of the therapeutic wheel. So this app will help. Moment you give them the duration of disease, what is the BMI, what is the EGFR, whether patient has established CVD or no, and whether there is a concern for hypoglycemia, and whether that patient can afford that drug. So based on whole information, I'm sure within 15 seconds you can get the best option from that app, which will be very handy and will be very useful in a clinical setup.
So looks like this approach gives a lot of flexibility in terms of individualizing the therapy for individual patient needs. And I believe that's the need of the hour, because our patients are different, as you correctly said. And we need to look into individual patient parameters before we decide on what drug is to be used. And this wheel and the app will definitely go a long way in helping physicians across the country to make the right selection for their patients. And understood, very important point is that irrespective of whether the drug is new or old, we have given more credence to the safety, efficacy parameters which are available for the drugs. So what does the guideline says about the parenteral treatment available in terms of insulins and the parenteral recombinant analogs?
Yeah, we are absolutely open to, because there is enough evidence today that analogs or biosimilars are almost identical, not only in terms of efficacy. In fact, before these drugs are launched, there is enough they have to produce before getting a US FDA clearance or today a DCGI clearance. So credibility of the drug is not an issue, because they have absolutely similar pharmacokinetic and pharmacodynamics before these drugs are launched, and these are more commercially viable. These tend to be more cheaper for the patient, and as per our own patient, we are again open to both the choices. Well, basal insulin, as given by ADA and ESD consensus, also tends to be the best option once your fasting is getting closer to more than 200 or HbA1c exceeding 9 or 9.5. Similarly, in our guidelines, RSSDI guidelines also, we said that if HbA1c is more than 9 and you have exceedingly high sugar symptoms like glycosuria and patient is not getting control with other drugs, a basal insulin or a basal biosimilar analog will be the best option. But well, as has been even in ADA 2017 onwards, we also said that for Indian patient, even a pre-mix analog or a pre-mix conventional 30/70 insulin are also very good option to start with, because of the fact that those are easy to start. You don't require too much of monitoring also, and for it is, I mean, easy to negotiate with the patient for 2 doses of insulin rather than going on basal plus or basal and bolus regime. So we are absolutely open to both premix options as well as basal based on the profile of the patient. If fastings are exceedingly high and HbA1c is 9, 9.5, obviously basal will score over premix. But if postprandial sugars are also high other than the fasting sugar, then even premix analogs or premix conventionals are very good option, because you need to intensify therapy to get their HbA1c closer to 7, what is treat to target.
So please accept our compliments for bringing this guidelines, and I believe a lot of hard work has been put into getting this guidelines, because it is not easier to accumulate all the data, read all the data, and then come up with conclusions which are very, very relevant for our Indian subset. And I'm sure this is going to help a large number of physicians and the patients who are really in need of these treatments. India being a diabetic capital, I think this was a much needed thing for the hour, and let me congratulate you and the whole body for bringing these guidelines, and I am very, very sure that this is going to help all of us, all the patients and the physicians community in a large way.
Thanks a lot. Yeah.
Thank you, sir. Thanks a lot for joining us today, and thank you for joining.
Thank you very much for your initiative and going back to masses and to all the physicians across the country, so that they get this message. And what we have as a result of evidence we have collected, I'll be very happy as a president of RSSDI if it reaches every clinic and every clinician can use that therapeutic wheel in the best interest of the patient. Probably that will be our great success. Thank you very much.